The Mental Health Task Force of the Resilience Committee at CORD would like to present You Are Not Alone, Recognizing and Responding to the Second Victim. We created this presentation to bring light to a very important wellness topic. You are invited to take this information and use it at your own facility to educate and help others.
I arrived to the emergency department at 7 a.m. to begin my shift. I had just taken sign out and sent my colleagues home to go to sleep. I received a call on our portable phones asking me to come to a particular room. That room is not normally one covered by my section, so I thought that was a little bit strange, but I went into the room anyway. And when I arrived there, I saw my resident preparing intubation equipment, an adult male on the gurney undergoing CPR, and a nurse and pharmacist by a code cart. I took size of the situation and ordered medications, reminded my resident to pop the C-collar for a better view, and began running the code. And as I was running the code and hearing snippets of information about the situation, I had a sudden horrible realization. The reason that there had been no encode for this patient and the reason that he was my patient and not the physician normally in charge of this section is that although we had never met, this patient already belonged to me. I had taken sign out on him 15 to 20 minutes before he attempted to hang himself in my emergency department.
The first victim in this case is the patient who died. The second victim in this case is the physician who cared for the patient. In 2000, the term second victim syndrome was coined by Dr. Albert Wu, a professor at Johns Hopkins. Second victims are healthcare providers, a doctor, nurse, advanced practice provider, student, resident, etc., who are involved in an unanticipated adverse patient event, in a medical error and/or patient-related injury, and become victimized in the sense that the provider is then traumatized by the event.
At this moment, each one of you is recalling a time when you were involved in a similar situation. We can all relate to this scenario and what is happening to that second victim. A wide array of emotions and responses could be occurring. You could be feeling blame, guilt, insecurity about your knowledge and skills, depression, anxiety, inadequacy, thoughts of leaving, or even thoughts of suicide. You lose trust in yourself. I believe many of us know the sickening feeling when you realize you made a big mistake. You don't know what to do. Should you tell someone? What should you say? You analyze the details of the event and replay them over and over in your mind. You beat yourself up thinking, I can't believe I did that. I'm the worst doctor ever. And if you have not yet had an experience like this, you will. Healthcare systems and providers are not perfect. Errors occur for multiple reasons, like system failures, lack of communication, and of course, human errors. Of course, we try to limit these errors as much as possible for the safety of our patients. But when patient harm occurs, in addition to addressing the first victim, the second victim deserves and requires support as well.
Despite our best attempts to prevent them, mistakes and errors will still occur. 1 out of 7 Medicare patients experiences a serious adverse event, and over half of those events are preventable. Consider how many providers are involved in the care of those patients. Greater than 50% of physicians report being involved in a serious adverse event in the last year. 60% of physicians recall an event in which they would describe themselves as a second victim. A survey of more than 3,100 physicians from USA and Canada found that 81% of those who had been involved in a clinical event, serious error, minor error, or near miss, experienced some degree of emotional distress. Even those involved in near miss events experience some level of distress. Symptoms reported include increased anxiety about future errors, decreased job confidence, decreased job satisfaction, sleep disturbance, and professional reputation damage. Other impacts on providers include isolation of staff, limited communication, negative impact on teamwork, low morale, impaired job performance, prolonged clinician suffering, negative personal and professional impact, and possibility that the staff leave their position or even their profession. Studies have also shown that after a patient safety event, second victims have been noted to have a higher risk of committing another medical error. Failure to address second victim syndrome can actually result in a vicious cycle of medical error leading to depression and burnout, resulting in further medical errors. This amplifies the need to have a support system in place for these second victims since it has a direct effect on future patient care.
Many people can relate to this picture, the story of a physician who had recently pronounced a patient and was taking a moment to compose himself before going to see the next patient. Yet in a survey, only 35% of people who have experienced a similarly traumatic event while working in the emergency department seek help. Debriefings can be profoundly impactful in a positive or negative way to providers. Done well, debriefings offer the opportunity to understand that others have walked this path before you and understand where you're coming from and are able to recognize areas for improvement without finger pointing or blame for an individual. However, done improperly without a value on the individual, people report difficulty with sleeping, increased fear of litigation or loss of trust from their colleagues, and increased depression and physician suicide. How can you identify a second victim? In many ways, it sort of looks like burnout on steroids. People may have emotional, cognitive, physical, or behavioral symptoms that help to identify when they are struggling. But oftentimes it can be through more subtle ways. Many times when there is a particularly tragic or problematic patient encounter in your emergency department, people hear about it. Instead of participating in the rumor mill, reach out to your friend or colleague and ask them if they're okay. Acknowledge that they may be struggling and that you're happy to talk. Send an email. If you're in resident leadership, don't wait for your learners to reach out to you. Instead, approach them and make sure that they're doing all right. And lastly, know the right time to reach out. When a person returns to a shift, having recently had an error, a bad outcome, or a problematic situation, talking to them about it at the beginning of their shift may, in fact, be detrimental to their focus and ability to work. So think carefully and thoughtfully about the best time to approach your colleague.
This picture shows what happens when you go through second victim syndrome from beginning to end. Stage 1 is the chaos and the accident response. So it's when the problem happens. Stage 2 is when you actually leave the situation and you start having some reflective time. You're thinking to yourself, okay, what did I miss? What did I do wrong? It can actually cause difficulty sleeping, trouble with your confidence, and you just replay the event sometimes in your mind. Then stage 3 is when you actually have to go back to work and you're dealing with the rumor mill and you're trying to reintegrate yourself. This can be scary. You may need help by a mentor or mental health assistance. You're wondering if people are trusting you or what they're thinking of you. Then stage 4 is you're enduring the inquisition or the investigation. You may be wondering, okay, is my license in jeopardy? Could this be a malpractice case? You could be having anxiety. You're wondering if you're going to be in trouble and what you should do. Then you have stage 5 when you're actually getting some help. You're supposed to be asking support from your family and your coworkers, maybe professional help as well. And then stage 6. This is the last stage. So you're moving on from this. You're either going to thrive, survive, or drop out. The people that drop out could drop out from medicine altogether or maybe just transfer to a different hospital. And this has effects on our hospitals. Studies have actually shown that hospitals that have second victim syndrome programs have decreased turnover and decreased missed work days. Then you have the people that survive, but they're just kind of plateauing. They're enduring it. They still have intrusive thoughts. You're coping with it, but you may have a persistent sadness, or you may keep wondering how you could have prevented this from happening. It's still affecting you. And then you have the people that thrive. These are the people that are able to learn from the situation and move on. They actually just gain perspective, and then they actually try to take the event and improve safety at their own hospital based on it. They try to make things better and advocate for their patients.
So how can we manage second victim syndrome amongst ourselves and our colleagues? The patients are increasingly complex. Our medical system is very complicated, and patients are going to continue to arrive in droves. There are several things that we can do, however. One is to put systems in place that aim to reduce errors by having checks and balances and promoting patient safety. We can also promote overall physician wellness and a culture that focuses on systems issues rather than an individual blame game. We have to recognize that medicine is practiced by people, and people make mistakes, and work on preventing those mistakes and also supporting those who have made them, while also still focusing on patient safety. We need true peer supporters and acute response teams, not comprised of people in suits who have never touched a patient, but comprised of our colleagues, trained psychiatric professionals, and teammates.
Sue Scott et al. Described the development and implementation of a 3-tiered clinician support program at University of Missouri. Their 4U team responds to all patient safety events focused specifically on the providers involved in the case. Several other programs across the country have also adopted similar models. The first tier that is the most important includes local managers, supervisors, departmental chairs, or colleagues. These leaders are given basic understanding of the second victim and simple steps to help clinicians after an event. Approximately 60% of clinicians recovered well if local support simply made sure they were recognized, simply asking, "Are you okay?" 30 to 35% of clinicians develop more intense emotional reactions to adverse events and require more in-depth support. The second tier group was trained to be formal peer supporters. These supporters provide ongoing one-on-one support, mentor second victims, and identify additional emotional support resources when needed. These supporters were specifically aimed in helping clinicians through the investigation process and any future legal actions. Tier 3, which typically accounts for 5 to 10% of clinicians, consists of formal emotional support, such as psychologic services, clergy, and employee assistance programs. The peer supporters were trained to identify specific criteria for referral to Tier 3. The program also provides emotional support and mentoring to the peer supporters. So what are the most important first steps, and how can you make a difference today? First, bring awareness to your department by educating your colleagues about second victim syndrome. Second, be a peer supporter within your department. Simply asking how the person is doing goes a long way. Allow them a chance to talk about their feelings. For example, "I can't imagine what that was like for you. Would you like to talk about it?" Normalize the situation. Most clinicians have all been in similar situations and can relate on some level. For example, you're a great doctor working in a very complex environment. Studies show that providers, up to 98% were reported, that were involved in an unanticipated adverse outcome wanted peer support. This form of support was preferred over support from a friend, spouse, or supervisor. Having the ability to discuss the case in a confidential manner with someone who understands the provider's profession, who can offer insight and empathy, has been shown to be highly effective in lessening the effects of second victim syndrome. Peer support benefits include credibility of peers, immediate availability, voluntary access to support, confidentiality, emotional first aid, not therapy, and ability to recommend or facilitate higher level of support as needed.
Many of us are able to recall these types of patients. Perhaps you carry with you the first patient you ever pronounced, or you are able to recall in vivid detail a patient who presented with shortness of breath only to throw a massive pulmonary embolus, arrest, and be unable to be revived. Why do we remember these so clearly? Perhaps it is because while you may not have known the terminology of second victim syndrome when this happened to you, you experienced some or many of the features of second victim syndrome. It is particularly important for those in resident education leadership or overall departmental leadership to recognize and understand these triggers in order to effectively identify situations where their colleagues, learners, or teammates could benefit from support.
Multiple hospitals, including Johns Hopkins and the University of Missouri, have developed large, formal second victim syndrome support programs. The usual steps to establish a program like this takes about 4 years. The steps are clearly laid out for you on the Medically Induced Trauma Support Services website, or mitss.org. There are 5 basic steps. First, you have to scan what support systems are already in place and available at your own institution. This could include chaplains, social workers, psychiatry, and employee assistance programs. These will be part of your second victim syndrome program. 2, you will need to survey the staff at your hospital to assess for both the awareness and prevalence of second victim syndrome. 3, you'll have to work with your leadership on buy-in and develop champions who can organize the startup of a formal program. 4, you'll have to formalize how medical errors will be handled with your risk management department. The patient's information must stay protected, and the doctor will also need legal protection in handling error disclosure. Last, you develop a formal operation for the program with protocols for activation and training the peer supporters. All of this, again, can be seen in detail on the mitss.org website. After the formal, large hospital programs at places like the University of Missouri proved successful and widely utilized, the experts such as Sue Scott came together on a panel to develop a downloadable toolkit. This toolkit has videos, surveys for your staff, websites, sample policies, and really everything you may ever need to develop your own program. The goal of the kit was to share strategies and tactics that have been successfully deployed in the United States. The toolkit's 3 modules include literature on emotional support, the panelists' existing programs and experiences, and literature for your healthcare leadership on affecting cultural change within healthcare organizations. After hearing about all of this, you may feel overwhelmed and be thinking, where do I even start? The first and most important step is creating awareness of what second victim syndrome is. Start teaching others how to recognize it, what situations may lead to this, and what to do if you suspect this. Remember the bottom tier of the pyramid. Just asking, are you okay, and being supportive is the most important step and the foundation of the support program. Consider doing a short slideshow like this one at your department meeting, grand rounds, or residency didactics. Then you can start looking more in depth at the MITSS toolkit. You can see the steps for forming your own hospital's program. You can start a discussion with others about forming a program and finding peers for the support and training them, as well as speaking to your hospital's leaders about the importance of this program. It will be a culture change, but you can be part of this important initiative in your department and within your hospital.
Going back to our original patient, what happened to him? Unfortunately, my patient did not survive his attempted hanging. Through counseling and support, my medical career and I did survive. And I have made it a personal goal to speak out about my time as a second victim in hopes of making things easier for others. I know that many people using this video will have or have had times in their lives where they experience symptoms of second victim syndrome. I hope that by engaging in honest conversation, more of us will not only survive but thrive in our ongoing medical practices.
In conclusion, it is up to us to support our colleagues and recognize the emotions that are associated with medical errors. Consider being a champion for your department or institution to help create a second victim syndrome program. Break the silence and talk about your own experiences to help others realize they are not alone. Contact CORD Resilience Committee and the Mental Health Task Force for further resources as needed.